So we are live now on Facebook and YouTube.
Hello, Dr. Rohit.
Good evening, Netra. Good evening, Dr.
Good
Nasir.
evening.
Good evening. Good evening.
Good evening. Good evening, sir.
Good afternoon. Good evening. Good evening. और सूर्य साहब नमस्कार.
Namaskar, Shyam Sundar. Namaskar.
Good evening, sir. Padma here.
Hello, Dr. Suresh.
Hello. Hi, Netra. Good evening.
We start in next 1 minute. We'll wait for 1 more minute. We are live now. All right, so good evening, ladies and gentlemen. We are here today for the series which we started on 26th of January, named as Freedom Series, a joint venture between the organization Indian Academy of Neurology and Association of Physicians of India. And today we have the president, Dr. Shyam Sundar of API, and myself here. Initially, when we started, Dr. Tiwari was the president, and it was a very coordinated effort. And I am glad that the series, which was started on 26th January, continued on 15th of August, and I think the phase one is last day, probably today for the 2nd October, but it's not going to stop. And I'm sure Dr. P.K. Maheshwari and Dr. Bansal, who are the coordinator, in continuation with the incoming president, then president-elect, at the present president-elect, Dr. Gagandeep Singh, will connect with Dr. Shyam Sundar and continue this series from December onward. As you all know that in November, we have the annual conference in New Delhi, which is Asian Oceanian Congress of Neurology with Indian Academy of Neurology. And probably for the first time in Indian Academy of Neurology annual conference, we have a session on with API, and I'm sure Dr. Shyam Sundar would come there and chair that particular session. Dr. Maheshwar will brief you. I would certainly want you to kindly come there so that we would like in future to have a similar session of Indian Academy of Neurology with API annual conference. I know that you invite a lot of neurologists in API conference. There are nearly 10 to 15 neurologists taking participation at their personal level from all across the country. But I want to feel that we should have a collaboration which should continue beside other neurologists who are part of the API. So I will say hello to all of you. Today the topic is multiple sclerosis. We have covered headache, stroke, epilepsy, neuromuscular disorders, peripheral neuropathy, and others. But I felt that multiple sclerosis is also something which physicians need to know because it can have the mimic, and an excellent panel of speakers. The chairperson will introduce them, and the great chairperson today, which will be introduced by Dr. Maheshwari and Dr. Bansal. So with that note, I once again thank API to listen to my request and take this series as one of the major joint venture, I would say, between API and IEN. And my wish will be, let this continue in the future forever so that there is a continuous training and teaching and cooperation between physician and neurologists continue, because in India, with a population of 1.35 billion, physicians are the first point contact, and they are the one who are seeing sometimes more number of neurological cases than even the neurologists. And that's the reason they really need to be updated, at least by us, and be in tandem. So with that note, I request Dr. Shyam Sundar to say few words before we hand over to Dr. Maheshwari and Dr. Bansal to introduce Dr. Padma. Dr. Shyam Sundar.
Thank you, Dr. Surya. Good evening to all of you. It is really a great pleasure to be here again at the joint Indian Academy of Neurology and Association of Physicians of India's continuing medical education program. And I mean, it is really the zeal of Dr. Surya that it is going on dot every month, and very interesting topics. And multiple sclerosis, when I was a student, most of our teachers used to say multiple sclerosis doesn't occur in India. But now you know that we are seeing these cases in India as well, and there is a greater awareness. I think this will be a very useful topic for the members of both the associations. So I wish all the success to this program. Thank you very much.
Thank you. And I request you to kindly come to Delhi for at least one day during the IronCon. This is my humble request.
Okay. I'll see.
Dr. Maheshwari, Dr. Bansal. Kindly introduce Dr. Padma.
Thank you, sir. Dr. Padma, very well known. She is Padam Shri, as well as presently Professor and Head Neurology Department in AIMS, and also Chief of the Neurosciences Center. She has got DM, FRCP, FAMS, FNAC, FIN, and also FNA. Her area of interest are the stroke as well as the multiple sclerosis. Publications are more than 300 and several projects on the stroke. Everybody knows about that. Her very much lovely topic in the stroke, including acute treatment strategies, restorative therapies, and stem cells in the stroke and cerebral palsy, post-stroke epilepsy, stroke in young, and functional imaging in stroke. She is also on the board for the National Stroke Surveillance Program, nodal officer for the stroke program for Government of India, Himachal Pradesh, Rajasthan, UP, Telangana, Andhra Pradesh. She is stroke mentor, National Stroke Prevention Program, and is the past president of the Indian Stroke Association. Now over to Dr. Padma. Says a few words.
Thank you so much, sir, and thank you, Professor Nirmal. Nirmal, thank you. I'm sorry, my voice is sounding terrible because I was down with viral for a while. So, when you're talking about multiple sclerosis, not for this August group, but I guess what the speakers would be taking us through this kind of journey through the trajectory of what MS had been. What we had known and those tectonic shifts in our understanding. So now we know that it is not simple immune-based inflammation, that there is a switch somewhere wherein it would just be inexorably degenerative. So now we know it's a neurodegenerative disease, and that's what we don't want it to be. We don't want the switch to happen. We don't want the switch to open. And so you have this huge spectrum of the medications we have in our arsenal to target various aspects in this trajectory. And I guess that is the understanding that has transformed our approach from a very generalistic autoimmune pathology to one of extremely precise and personalized and case-based management. And I think that's what the August panel will take us through today. And in fact, one of the speakers I called a rock star before Dheeraj had joined. And I must say that each one of them are really stars. So they're iconic in their field. We start with Professor Rohit Bhatia. He started the National MS Registry for this country. And I must say that's no mean task. And he's the author of probably the only, totally Indian approach or Indian effort-based MS book. He got out the second edition recently. And there are huge things, and I think he's given that momentum for the force of MS in the country. And being relatively young, he's achieved so much that he's welcome as a first speaker. And I said, Dheeraj has always been a rock star, and I've told Nirmal it's not just because he looks like one. He's also the one who's one tall leader in what he believes in both MS as well as in stroke. We have Dr. Suresh Kumar, who's iconic, and I had the pleasure, and I hope I do have the pleasure further also of meeting him and learning from him. And we have Dr. Nashli Chapuria. I don't see him. He's happily switched off his video there. Can we have you on board, Dr. Nashli? Because he is one really wise voice. At the end of it all, he summarizes what's there and gives you those pearls of wisdom. So I think there's a very, very interesting session on for the next couple of hours, and I'm sure it'll be a great, it will be a pleasure to be on board, and I welcome you all onto it. So, and to take us through all this, we have one little star who's actually become so bright. She sort of is her shine is, sort of overshadowing everybody else. And that's a beautiful girl there who's Professor Netravati. She is a professor from MHATS and who's really leading voice in multiple sclerosis, and she's going to moderate the session. So welcome you all, and over to you, Netravati.
Thank you, ma'am, for always being so wonderful and making me feel so nice in each and every session where we've been together. Thanks, Dr. Nirmal, Dr. Sham Sundar. So all of us know that multiple sclerosis now is revolutionized with so much of armamentarium in the therapy. Now today we'll be going through how we'll be starting the diagnosis, the therapy, and as ma'am mentioned, the case-based approach by Dr. Nasli. So first we'll have the first session. Can we have the
May I request Dr. Rohit Bhatia?
introductory slide, please? Dr. Rohit will be taking us to session on, he's a professor of neurology from AIMS, New Delhi. And his first passion has been in stroke and then in multiple sclerosis. As you can see that he's actually headed lot of sessions on stroke. And now he's also been the head of starting the MS registry for India, and where we all have been part of it. So today he is going to talk to us on the diagnosis of multiple sclerosis. Over to you, Dr. Rohit.
Thank you, Dr. Padma, Dr. Nirmal, Dr. Maheshwari, Dr. Sham, and Dr. Netravati for this kind introduction. So I will just okay. Can you see my slides? Are they visible?
Yes, sir. Yes, sir.
Okay. So I'll just give a brief overview about the diagnosis of MS. I think most of us sitting here and probably also listening to this talk have grown in our understanding of MS over the last 2 decades. And I feel that for patients who are very typical, it doesn't remain anymore a rocket science as far as diagnosing an MS patient is concerned. But then there are many things in between when patients come to us during the course of the disease where we have a bit of an uncertainty on the diagnosis. So I will start with a small case vignette of a 25 years old female presenting with an acute vision loss in one eye, which is preceded by mild pain for about 2 to 3 days. This typically evolves over 5 to 7 days. She has no history of fever, vaccination, or drug intake. A past history is unremarkable for any such event or any event unrelated to the vision. Her peak visual acuity is 6 by 60. The color vision is impaired. Examination shows relative afferent pupillary defect and fundus examination is normal. So when we see such a patient, the first thing that we have to make to our own self is that is my diagnostic possibility of an optic neuritis. So considering that she's a young female, she is in that age group, she has this pain in the eye, movement of the pain of the eye leads to pain, typically evolves over 5 to 7 days, and has this finding of RAPD, fundus is normal, you're bound to think of a possibility of an inflammatory involvement of the optic nerve, and you may come down finally after a lot of thought process that I may be dealing with optic neuritis. So when you're dealing with optic neuritis, then of course you have a set of evaluation plan in your mind, and that typically includes a workup with the blood, which is the hemogram and the biochemistry, and you target the immunological profile. You also think about imaging of the brain and the spinal cord, and you think about doing a CSF so that you can reach a possible diagnosis. So many times when you do all of these things, also you may not be able to find with certainty that you're dealing with a one particular situation. And in that scenarios, because we have many such conditions which are similar, like MS optic neuritis, a seronegative NMO, a MOG disease, or a monophasic illness, or whether this patient is a clinically isolated syndrome, may evolve and give us better understanding as time passes. But at the onset, we must have to try and filter out the different common diagnoses like MS, NMO, MOG, ADAM, and so forth. But think about other possibilities, whether it is vascular, whether it is neoplastic, could it be infectious, drug induced, genetic, or other immune system involvement. So these thoughts typically go in parallel when we are evaluating our patients in the outpatient clinic or even if they are admitted for a detailed workup. So in the first demyelinating event of any individual, you could have a presentation which could be of MS spectrum, which could be a CIS, a frank MS, or it could be an isolated optic neuritis or an isolated myelitis or a monophasic a form of a demyelination. So when we look at patients, we bring in different conceptualized planning, and then we slowly and steadily filter out our possibilities and reach to a possible diagnosis. So for a given patient, what is important? It is the clinical history, which is very, very important. It is the demographics, the gender, the age, which is important. You're going to not make a diagnosis of optic neuritis in a 75-year-old man with a recent onset headache where you would like to consider temporal arteritis. And of course, an imaging, which is an important part of a patient's evaluation. And I think in MS, imaging remains a very, very strong point in the diagnostic grid. Then we have important biomarkers, including CSF and few in the blood, evoke responses, and of course, exclusions, disease behavior, and response to treatment. I think all of this helps us give us a possible, method to put in place when we are trying to evaluate and make a diagnosis for our patient. With reference to MS, we've evolved in the criteria over the years. We started with the Shoemaker's criteria, which were a bit complicated, then Poser's criteria, which were still more complicated, and then came the McDonald's criteria, which were slowly and steadily evolved. For many years, we hinged on the McDonald's 2010 criteria, which evolved from the 2005 criteria, which then went on to a revision in 2017, which brought in an important component of MRI parameters and oligoclonal bands for the initial diagnosis of MS, even in the first attack. So what these criteria have evolved to say is that, one, we can make the diagnosis in a more simple and a straightforward fashion rather than making it too complicated. And MRI and a CSF and a clinical evaluation are important parameters to make a judgment that this patient has MS in the first instance or would have a likelihood of MS developing over a period of time. So the two important things that is always talked about in MS is dissemination in space and dissemination in time. So there are two components of dissemination in space and time, the clinical component and the radiological component. This image gives you the typical lesions that are seen in patients with MS, which are round to ovoid, discrete, not very large, not very confluent. They typically at the periventricular location or the juxtacortical location or the infratentorial location or in the spinal cord as discrete short segment lesions. Now, if you have more than two lesions in any of these four spots, this is suggestive of dissemination in space radiologically. And if you have lesions which are at two different places or clinical locations at two different places, that is a clinical dissemination in space for a patient. Similarly, if you have this patient who is following up over a period of time and then starts to develop these new lesions over a period of time, which could be any time after the first event, that will be characterized as dissemination in time on radiology. Or if the patient has an enhancing lesion, even at the initial MRI, when the patient is first presenting to you, is also dissemination in time, and I'll talk about it in the next few slides as well. Of course, if you have the CSF examination showing oligoclonal bands, that's also in the 2017 criteria, considered as dissemination in time, even if you don't have a radiological counterpart of enhancing lesion at the same time. So you could have a patient being diagnosed in the first go, that is after the first attack, like the example I showed you of an optic neuritis who would have all these lesions, who would have enhancing lesions, and we would have excluded other conditions. We would be with a lot of certainty able to say that this lady has MS and the attack is of an MS optic neuritis. So this is the way we look at it. However, clinically, if this patient develops a new attack, the one I showed you, let's say 6 months down the line, a spinal cord attack, which is a kind of a hemispinal cord syndrome, and patient is now started to improve with steroids, and the MRI also shows you no other explanation for this evidence, then this patient has a clinical dissemination in time. So patients who do not have imaging counterparts at baseline could have uh, clinical counterparts on follow-up. So you could have a patient showing up in the first instance radiologically, or patient could have no instance of radiologically, but a follow-up will help us decide whether the patient has MS or not. So, but the two core concepts remain dissemination in space and time, with all their limitations and criticism that we could have, because in clinical practice it may not always be possible to have both of them, in every patient, but you make a clinical judgment still that this patient has MS. So, if you're looking at a radiology of a patient of MS and you are considering dissemination in space by looking at two of the four lesions at two different sites, which I told you, juxtacortical, periventricular, infratentorial, and spinal cord, always look for a differential diagnosis in your lesions very, very carefully. And this is one of the papers which was published from Nature's Review Neurology, which talks about mimics. So you look for meningeal enhancement, you look for microbleeds, you look for infarcts, you look for cavities, and then you think about conditions like other inflammatory, NMOSD, whether the patient has Dawson's fingers or not. Could it be an ischemic pathology like a vasculitis? Could it be a migraine which is coming with the false, interpretation on the MRI, or leukodystrophies and so forth? Similarly, if you do not have these lesions which are present and you strongly think that this is not dissemination space, please carefully look for your MRI for all the possible etiologies and try to, think about the lesion that is present in its characteristic, its location, its pattern of enhancement, presence of microbleeds, how extensive the lesion is, and how the lesion is behaving on the imaging, especially if a patient is presented to you with a follow-up who also has a follow-up MRI. So many times you will, out of your haste, think that any small dot or any small multiple white dots in the brain are MS, but actually that patient may have presented to you with a different disease, and what you get on the MRI may have actually been non-specific or a suggestion of other diagnoses which have shown on this slide, which are like the usual ones which we all consider as neurologists or in clinic as well as in practice. So think about that in your patients as well. As far as the whole process of oligoclonal bands is concerned, and honestly speaking, before 2017, most of us were not hinging on presence of oligoclonal bands as strong diagnostic marker, but an associated marker. And these oligoclonal bands have 5 key things to know about. One, that in normal CSF, all IgG comes from blood by passive diffusion. It is generally polyclonal in normal CSF and serum IgG, and oligoclonal bands in blood give a mirror pattern in CSF. When we say intrathecal IgG synthesis, then these bands should not be visible in the serum, and they usually a sign of pathology. So that's why I recommended that we must send a serum and a CSF paired sample if you're looking for oligoclonal band. Just finding oligoclonal bands positive in the CSF and not having a serum sample is not worth doing it, because that really doesn't reason out the finding that it is an intrathecal synthesis. However, there are scenarios where you may not have oligoclonal bands positive, and that really depends on how you estimate the oligoclonal bands and what method is being used, because sensitive methods should be employed for estimating oligoclonal bands. A negative OCB does not really rule out MS, but if you have a pattern clinically which is different, you have a radiology which is different, and then just finding oligoclonal band and saying this is MS is not correct at all. So you must look at the clinical scenario, look at all your radiological parameters, and look at different scenarios that that could help. For example, in a patient where you do not have MRI finding of MS, but you strongly think it is optic neuritis, your NMO MOG is negative, your MRI is at this moment clean, but your oligoclonal band is positive, then this oligoclonal band may be reflecting that this patient has a high likelihood of developing MS and could actually become a prognostic indicator and strongly suggest that this MS attack, even though this is CIS, is actually probably in the continuum of an attack of MS, which is going to show up in the future. So all of these things will come to your mind, in parallel when you're evaluating your patient, step by step, especially in relationship to CSF oligoclonal bands. So what did the 2017 criteria actually put forward to us? It said that if you have 2 clinical attacks and you have greater than equal to 2 lesions, then this is very simple and you say that, okay, you have no better explanation, imaging is very characteristic, you can say MS. If you have one clinical attack and you have more than two lesions, then you have to demonstrate DIT by additional clinical attack. And if you do that, then you can say that yes, this patient has MS because DIS is anyway being supplemented by your MRI. However, if you do not have any of these, you do not have DIS, you do not have DIT, but you are thinking that this patient potentially could have had the first event which is related to MS, but you are not able to transcribe it over a follow-up or with follow-up imaging, then you have to keep this patient in the diagnostic grid of clinically isolated syndrome, which is generally a monophasic illness or an illness in the beginning which doesn't have frank counterparts to say that you have MS, but it is strongly suggestive in the continuum of MS rather than other diagnoses. So we generally use CIS term when we strongly consider that this attack of either a cord involvement or a nerve involvement or a brainstem involvement is actually closely placed to the clinical picture of a patient who has MS. Now, this could be supported by a patient's MRI, which is still not fulfilling DIS. It could be supported by oligoclonal bands, but no evidence of another attack. So all these patients will be then characterized into clinically isolated syndrome, which I have already talked about in the as far as DIS and DIT is concerned. So this is something which is important in 2017 criteria. So what has changed between 10 and 17? And that's really, really important for us to understand. In dissemination in space, we obviously needed 2 of the 5 areas of the CNS. However, we still don't count optic nerve because it is not considered very specific even in the 2017 criteria. However, what has really changed is that symptomatic brainstem and spinal cord lesions were not really included for calculating dissemination in space in 2010. It was said that if you have a symptomatic lesion, you should not take it into dissemination in space. Similarly, for dissemination in time, if you had an enhancing lesion in the area that you had actually presented with as a clinical feature, was not included in the diagnosis of MS. But now, if let's say a patient has presented with a cord lesion and the same cord lesion is showing enhancement, that could actually be taken as dissemination in time in the new criteria. So you can include symptomatic and asymptomatic lesions, but the optic nerve is not counted still, but which is counted in the Magnum's 2016 criteria. So this has really made the 2017 criteria have really made it more simple and straight and not very complicated for us to really consider the diagnosis of MS. But my last liner to that is that you are considering the diagnosis, but at the same time keeping all your mind open that you're not making a wrong, hasty diagnosis of MS, and you are considering all possible exclusions before you're labeling this patient as an MS. So for example, if you see this patient of optic neuritis who has normal brain MRI, who only has an enhancing lesion in the MRI in the optic nerve, no brain lesions, no cord lesions, and the oligoclonal band is positive, in that scenario, you are not supplemented by any specific diagnosis, but you'll have to keep this patient as a prognostic patient with MS, but can be considered to have, a likelihood that this patient has MS. Now, this is a patient again who has enhancing MRI because of optic neuritis, no enhancing brain lesions, multiple T2 weighted lesions which are discrete, no cord lesions. So this is showing dissemination in space, but we cannot use dissemination in time by the 2016 criteria because optic nerve is enhancing and that's a symptomatic side, and the oligoclonal bands is negative. So you may need another MRI on follow-up, or you may need another attack on follow-up, but there is a strong likelihood that this patient has MS. Inherently, we all know logically that this patient has MS rather than anything else, but when we're just placing our whole bet on criteria, then this kind of sometimes makes the whole thing very skewed, and I personally sometimes find that they just complicate the whole scenario when you are very certain that you're dealing with MS patient. This is another patient who has a cord presentation and the cord lesion is enhancing as well. The brain also has more than 2 lesions in 2 different locations. Even though the OCB is negative, this patient has an enhancing lesion in the cord. Patient has 2 or more lesions in the brain, and this is fitting into the new criteria of DIS and DIT, and you can very safely say that this patient possibly has relapsing remitting MS by the new criteria. So all these scenarios have been made simplified by the criteria, and you have to use your wisdom to reach a possible diagnosis. For the usual tests that we all do here is the standard blood test, which we do, hemogram, biochemistry, B12, folate, thyroid functions. We do viral markers, and if ANA is positive, ENA profile. I personally do it in parallel. I really don't wait for the ANA positivity report. And APLA workup for NMO and MOG at the same time, which really filters out many of the conditions. MRI and a chest X-ray if you're thinking of a sarcoidosis, a CSF analysis which we all would do in a patient who presents first time, maybe in a patient with 3 or more attacks who has classic MRI or imaging suggestive of MS. We may or really may not be very excited of doing a CSF, honestly, because this patient already has clinical events and radiological events. And in patients with optic neuritis, I personally think it's OCT which is more important than VP. VP only supplements your diagnosis but really doesn't help in anything else. Other in workup which could be there when you are thinking of differential diagnosis could be, doing infectious workup. In a patient where you're thinking of vasculitis or a Suzak syndrome, you can do angio or a fluorescein angiography, hearing assessment, electrophysiological studies, Schirmer's testing, PET. For other differential diagnosis, which is a long list we all know of all inflammatory, infectious, and infiltrative causes, need to be excluded in a given scenario where you are more than not certain about the diagnosis of MS. Where you are more certain on diagnosis, a basic step 1 investigation that I told you is probably good enough that you have excluded most of the conditions, but you may have to go ahead and rule out a patient's diagnosis. For example, multifocal white matter lesions, patient is relapsing, remitting, patient has taken steroids, but you're strongly contemplating a lymphoma. You will of course consider a biopsy in this patient. So I think this whole consideration is clinically judgment based rather than me making a long list of things that we will do in every patient, which is not practical and pragmatic as well. So if you have a patient with optic neuritis and patient is typical for MS, you can do a brain MRI and you can say whether the patient has a low or high risk. Similarly, if you have an atypical optic neuritis, for example, no pain, lot of retinal exudates, retinal hemorrhages, you are of course going to think about ischemic optic neuropathy, hereditary optic neuropathy, and so forth. And you'll do a list of investigations including MRI, CSF, serology, and other tests as appropriate. Similar is a patient who presents with features which are of brainstem involvement like internuclear ophthalmoplegia, multifocal signs, and your brain MRI is very characteristic, then you know that you are dealing with patients. But if you have an atypical MS like onset, for example, hyperacute, features of a vascular territory, then you are bound to consider other differentials like ischemic, infiltrative, inflammatory, toxic, nutritional, myelinolysis, clippers, and so forth. And you will end up doing the standard evaluation with MRI, CSF, neurophysiology, and other tests as well. The same is true for patients who present with cord lesions. If you have typical cord lesions which are semi, pure sensory, deafferented upper limb, which I think is very, very characteristic in young people who present to us, Lermit sign, partial syndrome, and of course your MRI clearly indicates lesions which is discrete, focal, partially enhancing, no long cord lesions, no long segment lesions. There is a chance that this patient has a possibility of MS, and you will supplement it with MRI, brain, and CSF evaluation. But if you have hyperacute onset, insidiously progressive, severe root pains, areflexia, does not remit, you are bound to think of compressions, ischemia, infiltrations, and all the possibilities we have considered, not forgetting an important differential of AV malformation and of course, deficiency syndrome. So you will again hinge at MRI, CSF, neurophysiology, and other serological tests that are appropriate. So all this brings us to one perspective is that you also will keep all the possible differentials always in mind when you are trying to make a mental exclusion of patients that, okay, now I'm very certain that this patient has MS because I've supplemented my clinical, I've supplemented my imaging, I've supplemented my blood work, and I'm certain that, I'm dealing with MS. But all these things that I told you about optic neuritis, about brainstem syndromes, about cord lesions, you have to keep in mind when you're evaluating these patients. And there are two important sister diseases, I think, which we should never forget. Example is this, that there is this young lady who presents with a focal neurological event. She was treated with steroids and given then subcutaneous interferons, thinking that she has MS. And if you look at this brain MRI, she has these peculiar lesions in the brainstem, which are kind of crossing the midline. Some of them are in the vermion, some of them are in the cerebral peduncle, some of them are close to the this middle cerebral peduncle, but they really don't give you a feel that these are MRI lesions of MS patient, because they just are too different than a usual MS patient. And the core MRI of this patient was normal, and then when she presented to us, she actually had hiccups and vomiting of 2 weeks duration, no other neurological disturbance, and she had a classic area postrema syndrome. MRI brain was clean, and her aquaporin 4 was positive. So we should never forget that these are the common scenarios which could closely be associated with the diagnosis of MS, and which would have very different trajectory of prognosis and treatment. A same thing about knowing that when you differentiate your MRIs of MS, like for example LETM, long segment optic neuritis, area postrema, brainstem lesions which are large and fluffy, and of course diencephalic lesions and cerebral lesions. So when you see all of this, you obviously think that no, I'm not thinking that this is MS. I may be actually dealing with something which is more typical of a opticospinal syndrome of NMO, or maybe a MOG, or maybe different diseases. This is another example of another sister disease which is evolved and which we have not become more understanding of, is for example patients who present with headache, episodes of drowsiness, mixed pictures with optic neuritis, ataxia. So this is a young girl who presented at the age of 7 to 8 years with all these different episodes. And if you see her MRI, this MRI shows involvement of both gray and white matter, a large gray matter involvement. But this lady was initially thought to have in the first instance that she has tubercular meningitis, because she presented with a lot of meningeal response, but then later was found to have relapsing remitting course responding to steroids, and was turned out to be an MOG positive disease. So we must understand that there are different spectrums of these disorders. MOG has more of gray and white matter. NMO has more of long segment optic neuritis and long segment myelitis and area postrema. So we must keep them all in mind when we are evaluating this patient. So in totality, you could have a patient who has MS, who has serum aquaporin 4 and MOG antibody negative, but high chance of oligoclonal bands. An NMO patient who has an aquaporin 4 positive, MOG negative, and a low chance of oligoclonal bands. Similarly, a MOG patient who will have aquaporin 4 negative, MOG positive, and a low chance of oligoclonal bands. So this will give you a fair idea, but I think what it comes from is first your clinical suspicion, your pattern of your MRI, your exclusion from the blood work, and of course your CSF evaluation. So this is probably my last slide to just show you that in imaging characteristics also that we have learned over a period of time, where the lesions are in patients with NMO, where the lesions are in patients with MS, and where the lesions are in patients with MOG antibody disease. So in my summary statement, I would say that that whenever you are evaluating a patient with demyelinating disease, you must take a thorough clinical history, the pattern of evolution of the disease. And I think the two important things that we typically hinge on are imaging, our blood work, and a CSF in patients who present to us for the first time. So keeping all of that in mind and keeping all the thoughts in mind, I think it is not really difficult to make a diagnosis in today's times, when we have really learned over a period of time how these criteria have simplified us our understanding. So I think that's more or less that I would like to cover, and I think then it will be taken over by Dheeraj with some part of evaluation and then the management. Thank you very much, all of you.
Thank you, Dr. Rohit. It was a very nice, beautiful presentation where you covered the whole journey, how the diagnosis of MS has evolved, where we used to count number of lesions in each area, 9, 4, 5, and now it has become more simplified, where even the CIS has almost been the first episode. Also, we are able to make the diagnosis of multiple sclerosis. I think we'll have the questions at the end of the session. So
Yeah,
we'll
probably, Netra, actually, I think the last slide was very, very informative to everybody. Very picturesquely, it describes the involvement of optic nerves. Very picturesque description, like, you say the visual impact is is better than 1,000 words. It clearly tells you the involvement of optic nerves in these three main differentials, the spinal cord and the rest of the brain. I think that's a beautiful imaging take-home message to differentiate these. I think for physicians, if this can go, it will be great. Thank you, Dr. Rohit, for that.
Even the three case scenarios which Dr. Rohit presented, especially when they come with optic neuritis and the myelopathy, with the different varied MRI presentations, actually those three case scenarios, if we are able to understand, actually gives the crux of how we should be diagnosing and differentiating between the sister disease, like how you told about NMO and MOG. I think these two, as Madam said, the last one and the three case scenarios actually gives the whole crux of the diagnosis of multiple sclerosis. Thank you, Dr. Rohit. Now we move over to the evaluation and management of multiple sclerosis by Dr. Dheeraj Khurana, who is a professor of neurology at PGI Chandigarh. Again, he also started with, he's also a person who is a great, as ma'am mentioned, a rock star, both in stroke as well as multiple sclerosis. He's a professor and of the Department of Neurology at PGI Chandigarh, and he has a lot of awards in stroke. And he's also part of the National MS Registry, where we all have been part. And now I request Dr. Dheeraj Khurana to give us how we should be doing after we have diagnosed multiple sclerosis. How should we evaluating a person with MS as well as management? Over to you, Dr.
Thank you. Thank you, Netra. Am I audible?
Yes.
Thank you, Netra, for the introduction. And it's great to be here. And thank you, Dr. Nirmal, Dr. Maheshwari, and Dr. Padma for the kind introductions. So I'll just share my screen. So Rohit has given a great introduction to the evaluation and diagnostic aspects of MS. So what I would be primarily touching is the general management principles and certain things about the various drugs, certain strategies that we can use, because it is very difficult to cover all aspects of management, even if I consider relapsing and secondary progressive. So I will just be talking of an overall paradigm of treatments in MS, and we'll try to cover certain aspects of drugs, because the armamentarium for drugs is expanding day by day. And just as Rohit mentioned, we have evolved in a significant manner over the years, and reaching up to the stage where we have our own registry now, which was unthinkable many years back, and thanks to the great efforts by Rohit. So I'll just again start with the case scenario. So there's this young boy which we had, who had onset of symptoms in January 13, whose diagnosis got confirmed very soon, and he had multiple attacks. If I look at the array of attacks throughout the years, almost every year he had an attack referable to either the cerebral brain stem, spinal cord, he was started on first line oral DMT, and he went on to have certain features like tremors and also attacks in between. And finally he was switched to a high activity agent called Tysabri or natalizumab. And if you look at the trajectory of the EDSS of this patient, this is prior to the starting of Tysabri. And we did see a slight increase in the EDSS, which is a disability scale indicating unilateral support at 6 to bilateral support, meaning thereby he was walking with a walker. And as the treatment with natalizumab continued, we saw a improvement in his EDSS, and he was able to reach EDSS 4, meaning he could walk at least 500 meters and could carry most of his day's activities. Over the years, he has been able to maintain a good degree of activity. However, symptoms still remain, like tremors, etc. The symptom control will, of course, be talked by Suresh in the subsequent talk. So talking about such a case, it makes me talk about something which I usually am quite pro for is treating early with high intensity treatments. And this characteristically represents an aggressive form of MS. So, what is aggressive MS? Many years back, if I would recollect, not talk alone of the time when I was studying DM, it was rightly believed MS hardly happens. But even over the years, we hardly had a concept. When I first started seeing MS patients, there was no concept of aggressive MS. Over the years, we've had this concept of aggressive MS and or a highly active MS. However, I'll try to distinguish the two things. So, what is exactly aggressive MS? If we see unexpected acquisition of disability, which is accompanied with a lot of relapses, like the case that we saw. So, a patient who keeps on getting relapses has uh, in incomplete recovery from the relapses, and usually these patients do not have adequate response to treatments by their most of the first line treatments. And basically, these are patients, if we would define them, we have more than two if we were to give an objective definition. If we look at 1 year, they should at least have two or more than two relapses with GAD enhancing lesions on the brain and a very high T2 lesion load, and they would fail a response to the adequate course of either beta-ferron, which was earlier being used, and or the other interferons, which no longer are first line of drugs usually, as people don't prefer it. So any other first line of drugs. So these people who fail, these patients who fail these first line and have poor response or poor recovery from relapses would likely be highly active or an aggressive MS. So there are certain common features in all these patients with aggressive MS. One is there will be a very early disability, and this disability would be intervening in between the incomplete improvements of the attacks, and would be accompanied by highly active MRI. So high active MRIs are the ones which have a number of lesions, increasing lesions, or GAD enhancing lesions. And this would also be accompanied by physical and cognitive deficits. So this is again an important aspect which is often ignored. We do not ask people about their cognitive deficits. And if we were to talk to them, we would find that these people do have increasing disabilities in the cognition. We do not have data from India about this. So a definition which has been evolving again, as I told you, a lot of things have been evolving. So to give a more objective definition, as was given by Rush in this review in Nature Reviews in Neurology. So if we get EDSS at least of 4 in the first 5 years, multiple relapses with incomplete resolution, and MRI, if we repeat the MRI studies, if we get new enlarging T2 or GAD enhancing lesions in the subsequent MRI, along with no response to therapy with 1 or more DMTs. So any one of these features, don't wait for all the features, but any one of these features should alert you to be dealing with an aggressive MS. And why am I talking of this? The reason is very simple, that the treatment needs to be aggressive in these people, in these patients, and we need to identify it at an early stage, because opportunity once lost is always lost forever in MS, which I'll be just talking about. So the defining characteristics, remember REM, relapse rates, disability in terms of EDSS, and MRI, these 3 things. And if we even have the slightest of suspicion with even one of them, we should be able to diagnose. And even now we have reached a stage where we can predict aggressive MS. So these predictions are, if this is a male who would have an onset at a elder age, a non-white race, is a smoker, again, those other characteristics of the relapse and disability remain the same, and maybe has progression right from the onset, even despite having relapses. So remember, the male, a higher age of onset, always be thinking of an MS with an aggressive nature, a T2 lesion load which is high, as is evident in this kind of an MRI, with GAD enhancing lesions and also subsequent MRIs showing enlarging lesions, a CSF which shows an oligoclonal band, as was just discussed in the evaluation. And now coming up, we have biomarkers like the neurofilament light chain. Very soon it is now getting increasingly available. We have data coming up that this can be done even in the serum and has high value in predicting high activity MS and an aggressive MS. It may be one of the best biomarkers available to us. So what are the therapeutic options? So if we have a patient who has a highly active or an aggressive course, we need to go aggressive in that patient. And the best agents considered to treat these would be the high efficacy agents like natalizumab, fingolimod, alemtuzumab, or bone marrow transplantation. For a usual RRMS, we have the first line agents, and a relapse therapy, of course, remains IV methylprednisolone. That is the main guideline, as the guideline states. So where do we face a problem? The biggest therapeutic crossroads, as I would call it, is if you have an MS where you've failed the therapy, and you might have to identify patients for switching, or you may have side effects with the DMTs. So these are the three major issues you face while you're treating. So how do we manage aggressive MS? We need to remember one thing again. I'm again emphasizing that these patients have a narrow window of opportunity. Because if we understand the treatment of MS, the usual course of MS, if untreated, of course, the disability may rise. And if we start the treatment later, there is, of course, a certain degree of disability which may prevent, and an early treatment which does prevent treat disability to a higher level. So we have a window of opportunity. Now, this window of opportunity, which helps us understand earlier treatment because of the way the pathology exceeds in or pathology proceeds in MS, this entire window is narrowed in aggressive MS, like as evident in this graph. So we still have a narrower time window where we should start treatment, and that too with an aggressive therapy, because there is a rapid accrual of disability and early treatment with an aggressive agent is needed. And the reason is inflammation is highly active in these patients, and the axonal damage which happens in these patients as time progresses is much faster in aggressive MS than the usual MS. So we might be dealing with a patient who goes into secondary progressive MS at an early stage. This usual time graph for RRMS going on to progressive SPMS and reaching higher EDSS is highly exaggerated, and in aggressive MS, and delays may lead to disability which cannot be regained. So we need to have main goals of our treatment have to be prevention of a relapse, delaying the disability, at the same time maintaining the quality of life, and having a good and risk-free treatment. So if we look at the DMT reviews, the DMTs that we have, we review the number of EDMTs. If we run through them, we usually have interferon, glatimer. Most of them, glatimer is no longer being used in our country because of its daily injections. The orals have been available to us. So the main, the safest one till now has been found to be glatimer. Even in pregnancy, it's the safest. The orals are one of the commonly used, and natalizumab, of course, is now, and other high aggressive agents have been now available. And this is the entire landscape of MS treatments as from the time they evolved. And if we look at the agents as they got developed, they were focusing mainly earlier on symptomatic, then reducing relapses and slowing the disease progression. But now all our treatments are focusing towards stopping the disease progression, which is, of course, as we understand, one of the worst outcomes of the disease, where once disability is achieved, we cannot reverse it, and that is the most troublesome symptom to the patient. So up till 2020, we have most of these agents available in the market or and then have been approved. And the most current molecules are the BTKI, which is a novel mechanism for these DMTs. And these are still under study and will likely get approval if the efficacy is proven. So amongst these, if we were to choose treatments which have, if we were to choose between a high risk efficacy, we have to choose, also be careful about the risk of the treatment. And in this Stephen Hauser's graph, which clearly tells us the more aggressive we go in our treatment, the greater is the chance of having higher uh, risk factors, or the risks with the treatment. And for example, natalizumab, mitoxantrone, autologous stem cell transplantation, alemtuzumab. So these are all high efficacy treatments, but also they carry a high risk. So with high gain and high risk is also accompanying them. So we need to identify treatments as per the, not only just the efficacy, but also their safety status with these, and also as which one would suit best to the best population. So if we talk of the induction agents, as I would talk in treating an aggressive form of MS. Now these are the ones, traditionally it was only mitoxantrone and cyclophosphamide, and this philosophy has been gained from the rheumatological disorders where they used high efficacy immune treatments. Of course, have in our setup for MS, fingolimod and natalizumab, which are continuous use agents. And there are agents which can be used for a finite time, namely alemtuzumab, cladribine, rituximab, of course, now, which is available, and ocrelizumab. And the definitive ablative therapies like the autologous hematopoietic stem cell transplantation. And the other treatment paradigm is escalation, where if you have a patient who starts with a treatment, who fails a treatment, you usually would try switching to another or escalate him with a slightly higher efficacy of treatment. And this primarily leads on to the two basic paradigms. Either we do induction or we do escalation. So induction is primarily based upon efficacy-based treatments, where escalation is a safety-based treatments, and this is how personal philosophies, they differ between physicians. So the treatment options in general, if we look at their mechanisms, could be either disease-modifying or they modify cells, because most of the treatments that we've been using have been modifying the T and B cells, and they either sequester disease-causing cells by like fingolimod, and they or hamper the ability of disease-causing cells to gain access, like natalizumab. So these are specifically talking of the high-efficacy treatments. But remember, the aggressive MS may even be resistant to these DMTs. So what we are left with now is the cell depleting or eliminating, which are chiefly the new age monoclonal antibodies. And these are mainly the alemtuzumab, cladribine, rituximab, and the newer agents I'll just refer to. So what we need to remember is, if an aggressive MS patient reaches us, we need to treat them aggressively, because that warrants an aggressive treatment. And these agents can lead on to their control. So let's talk of natalizumab, for example. So we have enough data which shows us natalizumab has high activity and compared to placebo. And the AFFIRM trial, which showed firstly the activity of natalizumab, was in highly active MS population, and it did show a very favorable relapse rate reduction, as well as a sustained reduction in the 12-week disability if we looked into the AFFIRM population. However, we need to be very vigilant with the use of natalizumab because of the risk of JCV, which is chiefly after 24 months of use. And we also need to look at JCV antibody status. So we usually get it at the baseline and keep repeating it every 6 months. So if you get a positive status, just remember the figure of 0.9, because beyond 0.9, the JCV antibody is positive, and the next cutoff is 1.5. And as the months progress, usually the risk of PML is low unless the patient has had prior immunosuppressant.
Is there a problem? Netra?
Yes, ma'am. I think his video is frozen.
Mitra?
To natalizumab.
Yes, ma'am.
Yeah.
We are not able to. Now we are able to
Yeah,
hear it.
he's got back. I think he's come.
What happened? Okay.
You were not audible for last 2 minutes.
The-
Okay.
You were disconnected in the middle.
Okay. Now it's
Yes?
okay. Am I audible
Yeah.
now?
Yes, yes, yes.
Yeah.
Okay.
Yeah.
So I'll just continue with so natalizumab and fingolimod are comparable. So if we take fingolimod, which is an oral agent and an S1P modulator, it almost has comparable annual relapse rate reductions, and also it does have some effect on the sustained disability progression. However, the importance of fingolimod remains that it's an oral agent, and it also has certain adverse effects like first dose monitoring of the heart rate needs to be done. And the Freedoms trial did also look at the NEDA, which is no evidence of disease activity, because it actually was one of the few studies which took care of all the parameters and looked into all the parameters which define the NEDA, and did show that 33% disease freedom from disease activity, showing thereby could be a very effective agent if you need to reduce activity. So, jumping straight on to certain newer developments in MS treatments, we now have new agents, new generation S1P modulators, for which the prototype has been fingolimod, a newer anti-CD20, the first agent being rituximab, which has now data coming up even from India, which has just got recently published. And rituximab has been very commonly used for all kinds of MS because of its low cost therapy. And the newer Bruton tyrosine kinase inhibitors. So if we compare the fingolimod to siponimod, which is the other agent which has recently been approved, this is one of the agents which is also now approved for secondary progressive MS. It has lesser adverse events than fingolimod. The anti-CD20 rituximab, I won't go into the details because itself rituximab can take a long time to discuss. But what I can tell you is rituximab is one of the very effective agents as cell-depleting agents, which can be used as an induction in aggressive as well as MS patients who probably cannot afford the other high-efficacy treatments like Tysabri. Its safety is well established by data, a lot of emerging data, a lot of data internationally, and recent clinical trials which have shown us the just a single randomized clinical trial which has been recently published. The newer like ocrelizumab or Ocrevus, as we know it, and ofatumumab have certain advantages over rituximab, and these are basically glycosylated. IgG1 humanized. So whereas rituximab is not humanized, and ofatumumab is human, totally human, and that's against the IgG1 kappa subunit of the anti-CD20. The other aspect of treatment, other type of treatment paradigm is escalation, as I talked of, which indicates the reason I mention it here is there are a lot of us who still follow the escalation paradigm, which may be practical in quite a few patients who do not have high disease activity. But this also carries certain rules that if you have to switch from one line therapy to second line therapy or a stepped approach, one needs to be careful about suboptimal responses, to identify a suboptimal response and to have a low threshold to switch to the second line agent, because usually what happens is there is a delay in starting a higher efficacy agent or a stepped approach to a second line therapy, and this may lead on to accumulating disability. We have enough evidence which tells us now that if you escalate, so instead of escalating, if you start with early intensive therapy, disease modifying therapy in MS. These are large voluminous population databases. This is from UK, which looked at early intensive therapy from a registry point of view. And we could clearly see people who had early intensive therapy did not have sustained disability accumulation as much as the people who were given escalating therapy. So definitely there was a delay or a larger number of people who did not have a disability accumulation. which is of course indicative of the fact that intensive therapy in the early phases of MS can help us prevent disability, which is one of the biggest important factors causing later reduction in quality of life. Another major agent is alemtuzumab as a finite treatment, which has very few doses to be given, just 2 times over 2 years, and is also currently one of the agents which may be utilized in patients who fail therapy. We only give 5 days of treatment in the first year and 3 days of treatment in the second year, and these are given by IV. But then it needs a long-term monitoring, monthly monitoring after the dose is given. And these are the 2 patients that we've treated, and these are relatively young patient. Now and both the patients had an aggressive form of MS. One of them had actually failed the treatments and had breakthrough with natalizumab. The second patient was actually given treatment as a treatment. Patient was naive, treatment naive, and we were able to. Patient was had from a very low socioeconomic background, and we were able to get treatment of alemtuzumab free of cost. So that's one of the reasons we talked to the patient, offered her this treatment, because this way she would not require treatment for the rest of her life. And fortunately, both patients, I'm going to say not just fortunately, they have done well. Sorry. And this, in fact, the treatment started just before COVID, and we have given the second doses post-COVID time, and they currently have been doing well without any relapses for the last 3 years now, 2 years, sorry. And the 2 biggest fears are the TSH, only one patient had a high TSH, which has also come down and subsequently, and the platelet counts have remained fine, because ITP is the other major side effect that we expect. The major side effects expected are the infusion-associated reactions, which both patients got in the first few days, and this can be well managed using steroids and just slowing up the infusion. So, of course, with excessive risk of these high efficacy agent, there are risks involved, but one needs to remember that we need to tailor these medications as per the therapy, and we cannot really attack aggressive MS with first-line therapies, and we need to personalize these medications. And another data from the Swedish MS registry also tells us clearly that high efficacy treatments, if they are given early in the course of treatment, the disability is way lower as compared to patients who are given a low efficacy treatments or escalation in the beginning. So this is again a large volume data from populations in the MS registry, Swedish MS registry, which is one of the most well maintained registry, with almost the entire MS population in that registry in that country. So this is almost the last slide. One of the agents, so talking of low resource setting, azathioprine has been even given a place in the guidelines and maybe an alternative in resource poor settings. It has a low evidence and mixed results, may be given to patients, and even the American Academy guideline gives some importance to azathioprine, and you can see that it is on the right side of the 0 line, and this has some efficacy in relapse reductions in RRMS. So it may be given as an alternate in resource poor settings, and we have guidelines to support this. So to conclude, we must individualize therapy. We should look at patients' needs and decide upon the therapy, rather than starting always with the same kind of a treatment and then escalating slowly. Early DMT usage is important, because that's the window of opportunity is very narrow, especially in the aggressive MS patients. And also we must have a plan drawn out for the careful monitoring of all these patients, depending upon the agent that you're using. For induction, always have a low threshold. I'm totally in for it. We don't wait for any kind of accruing disability. And depending upon the affordability, use the appropriate agent. If patient is unaffordable, I would suggest anti-CD20 like rituximab, but do give induction to these patients, and again monitor carefully for their side effects of the treatments. And once the treatment is controlled, we can probably shift them to low efficacy agents after a year or two. We have to be smart, as I would call. If you need to switch from a low efficacy treatment, we should do that at the earliest and identify any kind of a marker for highly active disease. We have all of them available, like MR, etc. So just to conclude, it's appropriate to Hippocrates, who said extreme remedies are very appropriate for extreme diseases, and nothing better example than MS. Thank you.
Thank you, Dr. Dheeraj.
Great. Very wonderful, Dheeraj. Wonderful. Did you touch on the NADA also as such?
The NADA, yeah, I just talked of a slide on NADA, but since NADA is, I think it's a created scale, which is important, but practically NADA is not possible to be observed in all our patients. It's a theoretical paradigm, which I think we all should understand, but to practically follow it in the clinic is difficult. If we're looking at best, what we can see is relapse rate activity or MRI and likely disability progression. But to combine all of them is around NIDA. This came as an aftermath of did not look into NIDA when they were being done for most of these agents.
Thank you, Dr. Dheeraj. I think you very well brought about that most of them would be aware of the relapsing and the progressive form, but we also need to see that we do not see that by giving inadequate therapy, we push them towards a progressive or the degenerative phase, and we catch them more in the inflammatory phase, and the importance of the escalation versus the intensive therapy. I think that was most important lesson what we learned from your talk, that though escalation may be good, sometimes it is more better to be intensive, especially in an extreme disease. The oath which you put up in the last slide telling about a disease like MS, it is more better we try to give an intensive therapy and not miss out on the inflammatory phase. I think that is most important. I request the attendees to post their questions and we will address them in the end. Dr. Maheshwari, you wanted to tell something?
No. Continue, Dr. Suresh Kumar.
Yeah. So now I request Dr. Suresh Kumar to take us with how to manage the complications of MS. As we all know, Dr. Suresh is a senior consultant of neurology at Renai Medicity Super Speciality Hospital. So his areas of interest, apart from multiple sclerosis, is Parkinson's and deep brain stimulation. He's been awarded the Dr. Ethan Samuel Memorial Award 2012-13 for the best research paper awarded by IMA AMS at Kerala chapter. Over to you, Dr. Suresh.
Very good evening to everybody. Thank you, Dr. Netra. Thanks to Dr. Nirmal for having us all here. Thanks to Padma Madam. Thanks to Dr. Maheshwari. And today, my topic for the day is going to be the symptomatic treatment of multiple sclerosis. So Dr. Dheeraj has now just taken you through the specific treatment of multiple sclerosis. And now I'm going to take you through the symptomatic treatment. So we know that MS is a polysymptomatic.
Suresh, your slides are not visible. I think you need to share your share screen.
Okay.
Hello.
Yeah, I'm just.
So click on the share screen.
Yeah, is it being visible now?
Yes, sir. Slide shows it.
Yeah. Is it being visible now?
Yes, sir. Yes, sir.
Yeah, right. Sorry. Sorry about that. And uh, good evening and thanks to everybody. So I'll be just taking you through the symptomatic treatment of multiple sclerosis today. So we know that it's a polysymptomatic disease, and you have a plethora of symptoms. It's not one or two symptoms. It's so many. You have fatigue, cognition and mood disorders, spasticity, gait and balance issues, swallowing and speech involvement, bladder and sexual dysfunction, whatnot. I think from head to toe, the patient is really affected by this disease. And our aim would be definitely to give them a good quality of life. And this is not possible by one single physician. You have to have a multidisciplinary approach with a lot of physicians getting involved, because some of the therapies are very specific and we may not know about everything. So what I would like to tell is that it's a chronic disease and you have a lot of symptoms, as I've already said. Many of them are non-visible symptoms. For example, a sexual symptom may not be visible to the physician unless the patient comes out with it, or a fatigue may not be visible to the clinician unless the patient comes and tells us about it. So that's why we need this multidisciplinary approach, because MS really affects the quality of life of the person who is affected by it. And there is an approach of looking at these symptoms as clusters, and I would come to you shortly what we mean by that. And most symptoms of MS do respond to disease-modifying therapies, as Dr. Khurana has already said, but the symptoms also need some specific treatment. So most of the time, we do not understand all these symptoms of the patient. So the most common answer we give them is, it's all because of your MS, and there's really nothing to be done. But is that the real scenario, or is that what? I think no. I think there's a lot of things which we can do for the patients as physicians. Now, you look at this iceberg and you see that there are a lot of things which are above the level of the water, and you can see the physical disability of a patient. You may be able to see clinical relapses. But a lot of MS is below the water, below the water iceberg. So loss of brain matter may just go on silently without us seeing, or a cognitive decline of the patient may just come in silently, and even silent MRI lesions. So it's always good to approach symptoms as clusters. Now, what do you mean by cluster? MS symptoms occur in clusters. Like, I just take one example of sexual dysfunction. It can cluster with upper motor neuron lesions and as well as spasticity of the spinal cord. Because when the spinal cord gets involved, all these functions are very close to each other and they can get involved together. Similarly, it can also be seen with pelvic floor symptoms, or it can be seen associated with cognitive symptoms, suggesting that probably the lesions are all higher up. So understanding these clusters will prevent polypharmacy and over-treating of these patients. Because if you take care of one of these symptoms, most probably the other symptoms will also be taken care of. Another similar cluster would be a cluster of poor sleep, fatigue, and nocturia. All this can be secondary to a neurogenic bladder. So you treat the neurogenic bladder and some of these symptoms would automatically improve. So when I just looked at my last multiple sclerosis data of symptoms of patients, over it's close to 352 patients. When I looked, we found that the motor weakness is the one which is maximum in the patients, close to 52%, and almost equally would be the sensory symptoms. If you look at the visual symptoms, mostly optic neuritis, it would be about 34%. And as you go down, you would get sphincter involvement, diplopia, dysarthria, vertigo, lower motor neuron facial tremors. Okay, so these could be all symptoms when you are first seeing the patient or the symptoms at onset. But when the disease progresses over a period of time, then the symptoms actually change for the patient. So they more complained about fatigue, which is seen almost in about 50% of our patients. They complain more of tremor as the cerebellar symptoms start coming in. Or they may be more affected by their walking or gait abnormalities. Depression becomes a very big problem at this stage. So does sexual dysfunction. And a very small percent of them also do develop seizures because of certain cortical irritation. Now, always when you look at the symptoms, such a chronic disease, as I said, patients always start complaining to you at every visit or outpatient visit. Now it's up to you to decide which of these complaints are real exacerbation or what we call the relapse, and which of them are pseudo exacerbation. Now, why do you want to differentiate between these two? Because for a relapse, obviously you would give steroids, mostly IV methylprednisolone followed by oral steroid. So you want to be absolutely sure that each time you're treating the patient for the right reason and not simply keeping on adding steroids at every visit. So how would you know this? If you just take it simply, exacerbation would be something new in the character of the symptom. It would be much greater in intensity, and it would most probably in a new site from the old sites where the patient had problems. The pseudo exacerbation mostly would be in the same site. If the patient has a sensory symptom on the left half of the body, the next time also the patient would come and tell you, yeah, I have this symptom on my left side, but it seems to have little increased. So you would worry if that was a relapse. Most probably it would be a pseudo exacerbation, maybe associated with a fever or temperature change or something. You have to go and take that history. And these pseudo exacerbations are of much milder nature than an exacerbation. So I would take you through this symptom treatment through some of my cases. These are cases which we saw in our clinic, and try to explain the symptoms through these cases. Now, a 38-year-old man working as an IT firm was diagnosed with multiple sclerosis in the year 2014. His complaints were that he was finding difficulty to cope with his work. Now, he was in the IT business and he had brain. He had become slow. His wife revealed that he was always absent-minded from the very beginning, but of recent he has started forgetting where he has kept his car keys. He cannot recollect people's name now. And while driving, he was not keeping to his lane. He always tended to go away to the one side. His wife found him fatigued all the time, though his motor abilities were very good. He missed on a chance of a promotion at his office because of his sluggishness. He suffered from excessive daytime sleepiness. He was having difficulty in initiating as well as maintaining sleep. He had no motor weakness because he was driving to his office. But you see the other symptoms which he has. He was having an independent activity of living, activity of daily living. But still he was so much affected by the disease. We started him on dimethyl fumarate, seeing some of his MRI lesions. He's been taking the medicine for about 6 years now. And he does his exercise religiously along with some yoga, and he still goes to his office, still drives to his office. So this is his lesions in the brain. If you see that, why he has more of cognitive, most of the lesions are around the corpus callosum, the area, and some of them are periventricular. He doesn't have any brainstem lesions. So mostly his symptoms have been cognitive. Now, let us come through his symptom. The first thing his wife said was fatigue. So fatigue is one of the most frequent and disabling symptoms. It occurs suddenly without any reason for the patient. And they just come and they will be okay in the morning, evening, they would come and say, I'm really very fatigued now, I can't do anything. This is more in the afternoon and usually is aggravated by heat. It's not related to the disease duration as such, because quite early in the disease itself, one can really get a lot of fatigue. And definitely it affects the quality of life of the patient. So if we go to approach the fatigue treatment as such, One should always rule out depression and hypothyroidism in such patients. You should also evaluate for sleep disorders like insomnia, obstructive sleep apnea. So if these things are sorted out, then actually it could be a fatigue due to the multiple sclerosis disease itself. Then you have all these options of treatment. You have cooling therapies, which has a level A evidence. You can give amantadine or 4-aminopyridine, which has got again a level A evidence to give that. Then you have L-acetylcarnitine, which is in level B. And now we give modafinil, which is a level U evidence. And you can also ask them to do isometric exercises, which helps a lot in fatigue. The second problem he had was cognitive impairment. Now, cognitive impairment need not be only due to cognitive neuronal loss. It can be precipitated by fatigue in that same patient. It could be precipitated by depression and anxiety. It could be due to his sleep disruption, and also maybe due to some of the drugs you're giving. Probably if he has some bladder issues and you're giving some anticholinergic drug for the bladder, which crosses the central nervous, blood-brain barrier into the CNS, then obviously the patient would have some memory issues. So you have to be really careful when they complain of cognitive impairment and see whether your drugs are the cause or it is something else. So based on whatever you find out, you have the options of giving them good diet or healthy diet, which can improve, memory enhancing diets, what they call. You can put them on a good physiotherapy, which will help them definitely. Being active, improves your memory. You can give drugs like dalfampridine for your fatigue and donepezil maybe for enhancing the memory, but avoid polypharmacy in such patients. Find out what exactly is the issue and try to address it rather than give a lot of drugs together. Now, this is the second patient. This is a 36-year-old male patient who's working as a bank officer and has got presented to us with severe paraparesis and bladder symptoms. He had a history of optic neuritis 2 years ago. He was diagnosed based on the McDonald's 2000 criteria, which Dr. Bhatia had already told us earlier. Initially, he was treated with IV methylprednisolone followed by oral steroids. He had bladder urgency and urge incontinence when he presented to us in the hospital for the first time. The MRI brain was quite typical of MS with multiple lesions of the spinal cord and the brain. Later, he had another episode of myelitis after a couple of years, while he was on interferon beta 1A, which we had already put on, which is Evanex. Considering to be a case of more aggressive disease because he was worsening on interferon beta, we put him on the injection natalizumab, which Dr. Khurana had already told us. His motor symptoms improved to some extent. He was able to walk with natalizumab after some time. However, he feels like his legs were very heavy, as if he had to drag his legs along. And his wife told us that he had decreased sexual interest of recent and had erectile dysfunction. His bladder symptoms, however, improved. Now, this is the MRI. You could see the initial MRI. The first time we saw him, you could see the lesions in the dorsal cord, but not much in the cervical area. The same patient, when he was after 2 years again, you could see this time the hyperintensity in the cervical cord, while the dorsal cord lesions were improving. So spasticity is a very poorly understood symptom of multiple sclerosis. Approximately about 90% of MS patients experience at some point in their life. It's a combination of axonal degeneration and demyelinating plaques which happen in the spinal tract. Sometimes it can be a useful symptom. For example, if the patient has proximal muscle weakness or weakness at the level of the knee, then the spasticity can be helpful because it will help him to actually walk, even if it is with stiffness. So it can be a blessing at some time, but most of the time spasticity is not a good symptom because it interferes with the patient care. Spasticity can lead to abnormal posturing. It can lead to bladder issues. So it's not generally a good symptom to have. Patients should be made aware of the presentation and avoidance of triggers which may worsen spasticity. So if you look at spasticity, there are two types of spasticity. One is the phasic and other is the tonic one. The phasic one is usually what we see initial part when the neuronal injury happens in any patient, and the presenting symptoms would be spasm, cramps on the muscle, and also clonus. while tonic one actually appears over a period of time, and then during the tonic phase, the patient predominantly complains of stiffness as the main. So you need to avoid triggers which can worsen this spasticity. So while treating, the goals of treating spasticity would be definitely to reduce the pain, because spasticity produces a lot of pain in the patient. It will also help in facilitating of nursing, because if you have a patient who's very spastic, it will be difficult to turn the patient around or make him sit or make him stand. So if you reduce spasticity, it will facilitate nursing. It will also improve motor functions of the patient, because spasticity will leads to reduction of spasticity leads to greater mobility of the joints. And it also, the role of treating spasticity is to avoid contractures and pressure sores, which are very important. So if you look at spasticity chart, basically you can do things like yoga, stretching, exercises. This can reduce spasticity. Otherwise, you have three main pillars of treatment. One is physiotherapy, other is oral medication, and third is the interventional drug. So physiotherapy would be predominantly gait therapy, specific posturing therapies, hydrotherapies, and also cooling therapies, like you can make the patient wear cooling vests, etc. If you look at oral drugs, there are two main drugs, which is baclofen and tizanidine, which are muscle relaxant acting centrally, and also gabapentin. All the three have got a level A evidence in the treatment of spasticity. Interventional drugs would be like injecting specific drug like botulinum toxin into specific muscles of the upper limb or the lower limb. Or you could even use intrathecal baclofen, which can be used to reduce spasticity after doing a baclofen test. The third main problem in the patient was the pain. So MS-related pain syndrome is quite common. It could be directly related to the MS diseases, such like acute optic neuritis are very painful. Pseudoradicular pain will be there. They can have paroxysmal pains like trigeminal neuralgia. They can have a central thalamic pain, or they may have pain, secondary headaches. So all this could be related to the MS diseases. They can have indirect pain because of their joint muscle related, as I said, due to spasticity, pressure sores, or visceral entrapment. They could have drug-related pain, because in the old times when we used interferons used to cause a lot of pain, local side pain and muscle pains. And they could have, independent to all these, like in a low backache or osteoporotic disease, like any person, they can also be prone to a primary headache like a migraine. So we need to treat all this in a patient with MS. So the MS pain syndrome, you should ask the patient to maintain a pain diary, like we maintain headache diaries. And treat specifically. For MS-related disease, you can treat them with gabapentin, pregabalin, carbamazepine, lamotrigine, or topiramate. All of them have got a level A evidence. Antidepressant, tricyclics, and the newer drugs, we have a B level evidence. And then you have opioids, and also cannabinoids are used now. Indirect effects would be pain, like doing physiotherapy, occupational therapy, nursing, drugs. So, you have to take care of these things. If the patient has got a pain, you can get a registered dietitian to give them good diet. Drug-related pain could be again due to the, interferons. So you use analgesic, cold packs. You can give a low dose of steroid. All this have got a level B evidence. And independently, you can treat them with physiotherapy and appropriate therapy. These have a level A evidence. So regular exercises, like in gentle forms, Tai Chi is being done nowadays. Optimize the diet of the patient, stress management. All this goes a long way, in helping patients with MS. Some people even go for acupuncture, whatever helps. Now, sexual functions is seen about 50 to 90% of males and 40 to 80% of females. Erectile dysfunction can be seen up to 80%, and hypoorgasmia, reduced libido, and reduced vaginal lubrications can happen in women. There is positive correlation between lower limb weakness and fatigue in women. And it leads to a lot of partner dissatisfaction and, ultimately ends up in divorce in many of these patients. So when you look at the sexual dysfunction, the problem for both individual and the partner need to be addressed. Females, reduced libido and lack of orgasm could be a problem. For males, it could be erectile dysfunction. You could treat them like primary, it could be a MS-related, problem. Secondly, it could be due to spasticity, bladder or pain. And tertiary, it could be due to psychological issues, which may be leading to the sexual dysfunction. So treatment of sexual dysfunction, it should be a complete neurological and history of sexual related history. You have to take it very detailedly. Neurological examinations have to be done absolutely, complete. Appropriate neurophysiological studies have to be done. Stop drugs which may interfere with sexual dysfunction and start counseling. Drug therapies for the males would be all the sildenafil and the newer variants of that drug. Apomorphine can be given. While for females, it could be estrogen-related creams or agents which can be used. Invasive and surgical treatment would be prostaglandin injections, penile prosthesis, or vacuum pumps, which can be used. Bladder dysfunction is again a major problem in patients with MS. It could be higher bladder, UMN bladder, or element bladder. For higher bladder functions, it could be due to a disinhibited bladder. UMN could be a VSD, or which is vesicospastic dyssynergia, or it could be spinal cord related irritation. Element could be due to involvement of the sacral segments of the cord. So you have to treat them with pelvic floor and core exercises, avoid bladder irritants, avoid coffee, alcohol, limit fluids, schedule their voiding time. Pelvic floor physiotherapy is a must. You should get a urology evaluation in such patients. Self-intermittent catheterization should be trained in such patients. You could also, give them drugs like antimuscarinic drugs. So the older drugs had more of anticholinergic effects and they used to cross central nervous system, but the newer drugs have got less effects and they are preferred now. Botulinum toxin can be given for bladder irritation. Tibial or sacral root stimulation can be done. And suprapubic catheter placements is done in certain patients with bladder involvement. My last case would be the third case, which is a 28-year-old dentist who presented with difficulty in holding objects. Predominantly, she was not able to hold her tools while she was working at the dental clinic. She also had minimal intentional tremor of the right hand right from the beginning. She had a mild ataxic gait. MRI was very typical of MS. CS of OCB was positive. Initially, we started on interferon beta. She didn't do well. Later, we changed to natalizumab. However, she continued to progress on that. Her EDS worsened quickly from 3 to 5.5. She didn't want any more DMTs further. She really went down over a period of next 4 or 5 years. She's no more. And she had a lot of mood disorders with severe depression and pathological crying towards the end of her life. And this is her first MRI in 2009. And then we have one in 2012. But quickly you see how in 2012 and then after that in 2013, how the MRI actually started being, getting more and more worse. And so did her symptoms. So dysphagia is a major problem in such patients who would reach the end stage of life. It can vary between 22 to 54%. Most of them present with recurrent cough on swallowing. They have increased siluria. Recurrent aspirations can lead to pneumonitis. There's a profound loss of weight in such patients, and definitely the quality of life goes down. So in such patients, you should always do a screening questionnaire. And after that, you should evaluate them with a flexible endoscopy, FIS or VVFSS. You can modify their feeding, teach them orofacial exercises, or also swallowing maneuvers can be done. Or you can give Botox injections at the sphincteric level, or you can use cholinergic drugs. Nasogastric tube, nasojejunal tube, PEG treatment would be the last resort of treatment in such patients if the others do not work. Tremors is disabling. 80% of patients have ataxia. It could be due to cerebellar, spinal, or sensory ataxia. Most of them have truncal tremors, upper extremity tremors, ataxia, distal intention tremors, which are very disabling. Symptoms can fluctuate throughout the course of the day in such patients. So tremor and ataxia, the treatment should be physiotherapy, weight, relaxation, cooling. Drug therapies like beta blockers, carbamazepine, primidone, clonazepam can be given for these tremors. And surgical treatment could be for resistant tremors, deep vein stimulation, and lesion activities. Dysarthrophonia is another problem. The neurologist, otolaryngologist, and speech pathologist should see these patients together, give them speech therapy, and ask for behavioral techniques. Drug treatment, Botox toxins again can be given here, and phonosurgical operations can also be done by the otolaryngologist. Gait in MS is a problem because they have usually decreased stride length, increased steps per minute, which is called cadence, slow free speed walking rates. They have less rotation of the hip, knees, ankles, leading them to a stiff posturing, increased trunk flexion, reduced vertical lift in central gravity. Overall, they take short, quick steps with a lot of balance issues and loss of full range of mobility. This leads to falls, and the most important sequelae of gait and imbalance problem is falls, which can lead to fractures and many injuries. Lastly, some paroxysmal events which you may see with MS, which is like trigeminal, glossopharyngeal neuralgia, pseudoradicular pain, sensory symptoms like paresthesia, dysesthesia, Lhermitte's sign, paroxysmal ataxias and dysarthrias, paroxysmal dyskinesias, facial myokymia, palatal myoclonus, Uthoff's phenomena, ocular symptoms. All these can be seen as paroxysmal events in patients with MS. The role of exercise is being increasingly advised. Adherence to exercise can yield a partial reduction to fatigue. Aerobic exercise is particularly important in patients who are overweight. Definitely can be done in the milder EDS stages of the patient. Muscle strengthening is very important. And also you should motivate the patients, to do this active exercise at least 3 times a week. So the last slide would be what would be the take-home messages. MS symptoms should have a multidisciplinary approach, surely. Approach MS symptoms as clusters, not as individual symptoms when they happen in a polysymptomatic way. Avoid polypharmacy in these patients. The importance of diet and exercise and non-pharmacological intervention is equally important, though in many cases, evidence-based medicine is lacking in these areas. Treatment should be highly personalized in patients with MS. Thank you.
Thank you, Dr. Dheeraj, Dr. Suresh. You very well brought about, especially the invisible symptoms about how we should be dealing. Most of the time we talk about either the disability, optic neuritis, myelopathy, or gait dysfunction, but there are so many non-visible symptoms which actually affect the patient as well as the caregivers, and it is very much important to address those issues. It was a very nice talk on all these symptoms. Ma'am, you would want to tell something? Dr. Padma?
I was looking at the time, Netra, so I think
Yeah.
we'll go to Nashli's talk and then we'll take up the questions. I think it's 6:45.
Now,
Yeah, I'll finish fast. Don't worry.
Dr.
No,
Dheeraj,
no, we wanted to, hear you ASAP. So welcome, Dr. Nashli.
Yeah, but I've just got one case.
welcome Dr. Nasli Chaporia. He's a senior neurologist at Sayadri Hospitals, Pune, who has done MBBS, MD, and he doesn't require any introduction. And because of lack of time, I think we'll go over to your talk, sir, which is going to be very helpful, especially the case-based approach.
Yeah, thank you so much, Dr. Netravati. Yeah, let me see. Yeah, I presented this case some time before also, but there are many new people. So I thought I'd take this case. And I've been seeing this patient for the last decade or so. So, we'll go through all the things that happened in this patient's life during her journey with MS. And many, many small little things to learn from this experience. So this was a 20-year-old female medical student. She presented with squint, diplopia, and pain in both eyes. This was in many years ago, I think 2009. And MRI was reported as few white matter lesions. That time our understanding of MS was rather primitive. So this is how it went. And this is how the story of MS has evolved over the last 15 years. And now, as Dheeraj said, so many new treatments have come. And that time we didn't have so many treatments. So she was on oral steroids. She was given oral steroids and the symptoms were relieved. Again, she had gait ataxia. Repeat MRI, no additional findings. And again, now she was started on interferon beta 1A intramuscularly weekly, that is Avonex. And that time you must remember that only Avonex was available and there were hardly any drugs. Even that time it was very expensive to get it. So this is how she was treated, not by me, she was treated by some other neurologists. And this was her MRI. Unfortunately, I'm not able to see the dates. Yeah, anyway, can you see the dates?
It's 2008, July
Yeah.
2008.
Yeah, it's getting covered by the thing, so I can't see it. Anyway, this is in 2008, and as you can see, there are all these white matter lesions here, and already quite a significant disease load. Yeah, and you see here some more pictures, and she was on beta interferon 1A. Once a week. Again, she had right facial palsy, ataxia, numbness of all the forelimbs, and methylprednisolone was given. So the story kept on going on for some time. And this is in 2009. Already now you can see, it's very important to see this, that, already cortical atrophy has started coming, so this is a very important point in MS, that it affects the cortex also. All the time we used to think that it's only the white matter, but it affects the cortex, and there is cortical atrophy that gives rise to cognitive decline and decrease in gait and various other problems. So Avonex was stopped, and in January 2010, 2011, patient was on Relibeta. This was a biosimilar interferon, no placebo study, with another physician. It was very difficult at that time, 2010, to get these drugs. You should understand that. And in January 2011 to March, no interferons were given. She went on to the PEG interferon study. Study had a placebo arm, again with another physician. And another physician shifted, the patient was not doing well. She was getting attacks again and again. And another physician shifted this patient to glatiramer acetate after the MRI had shown certain worsening. So, there was very little in our therapeutic armamentarium at that time. And this now you see, now you see the gross cortical atrophy, which has already occurred. So this is how the disease has progressed. You see the brain has shrunk actually, and the corpus callosum has become so thin, and the ventricles have become so large, and the gray matter has become so thin. And in November 2013, she was doing her medical internship. She had struggled to pass MBBS. She had severe gait ataxia, spastic gait, needed a person's support to walk. There was severe tremor on intention in the right upper limb. She could not write, and she had dysarthric. This is one of the most severe tremors I've ever seen. The hand was shaking all over the place, and she could not even hold a cup or a pen, and could not eat with the right hand. She was depressed and despondent. As Suresh said, depression comes in not only because of disability, but because of the brain lesions. She and her doctor parents were desperate, uncertain, and very anxious. And this was her MRI. You see the cortical atrophy. And now the white matter lesions have become confluent. So, initially, as you saw, they were patchy in the white matter, but now they've become confluent. It's almost like, leukoariosis, which occurs with lacunar state. So it's becoming like that, and it's like Faseca's grade 3. So this is how the disease has progressed, and you see the ventricular size also has increased, and the cortex has become so thin, and there is so much cortical atrophy. And this is the other picture. Again, it shows the extensive and confluent white matter lesions. And a spinal cord had also become rather thin. There were no lesions, but if you see here, the cervical spinal cord had become thin. So now what do you do with such a patient? She was already SPMS, that is secondarily progressive multiple sclerosis. She was first RRMS, that is relapsing remitting MS, that is early. The MRI is looking horrible. There are diffuse and confluent white matter changes. There was severe cortical atrophy, the brain of an elderly dementic. She had fixed neurodeficit, and she was JC virus antibody positive. But then we were thinking, now there's really nothing much we can do. But then we said, okay, let's do the contrast scan. And lo and behold, the contrast scan showed these ring enhancing lesions, as you can see here. So though she was SPMS, she was active SPMS. That means there was still inflammation. As has already been told, initially there is inflammation in the brain, and MS is an inflammatory brain disorder. And later on, because of the extensive inflammation, there is degeneration, and the brain starts atrophying. But here we see that atrophy has already occurred, but still there is active inflammation. So this contrast scan very clearly showed that there is active inflammation in the brain. So then at that time, we didn't have, we didn't know much about rituximab at that stage. So we said, okay, let's use this natalizumab for her. And as you see this flow diagram, I won't go through it, but what is important is if the JC virus status is positive. At that time, we didn't have the not the titer, it is called the index, JC virus index. At that time, that paper on JC virus index had not come. So it was just positive and negative. And as she was positive, her risk of getting PML was like this. So if you use it for the first 24 months, the risk is very low, just 1 in 1,000. And and if the person has received steroid or azathioprine or methotrexate in the past, then the risk goes up. So she had not received, luckily, not steroid, the azathioprine. She had not received any of these. So we said that her risk stratification is relatively low, 1 in 1,000. She was not negative. Then if it is negative, the risk is very low. You can give natalizumab with your eyes closed. But many of our patients are JC virus positive, so one has to be a little careful. So we explained this to her parents. Parents were doctors, so they understood everything clearly. And if you see the lifetime risk from dying, airplane crash 0.5 per 1,000, drowning 1.1 per 1,000, fire 9 per 1,000, automobile accident 10 per 1,000. In India, it must be 20 per 1,000. And we stroke people, symptomatic ICH after TPA is 40 per 1,000. So, we are risk takers. We stroke neurologists are risk takers. So we said, oh, look at this risk. And her risk is just 1 in 1,000. So let's take this risk. And now this is very important for us to understand in the treatment of MS, is that brain volume decreases in MS. As time goes on, brain volume decreases. So if you have RRMS, the brain volume decreases by 0.49% per year. If it is CIS, little less, 0.4, PPMS, 0.56, and SPMS, 0.64% per year. So a person with SPMS of 20 years duration develops atrophy of 12.8%. That means 180 grams That is, you go back 180 million years, you become a Neanderthal man. So, the brain atrophies. So this is another thing which is very important for early treatment and aggressive treatment of MS, that the brain atrophies and cognitive decline and dementia can occur in patients with MS. So there is urgency of treatment. So all these factors put together made us think that we should start natalizumab after some discussion. And there was a lot of discussion. It was a new drug at that time. Our experience was limited. The world experience was there. So we looked at the world experience. The parents talked to their family, and, back and forth, it went on. And what were we really expecting? We did not expect the fixed deficit or cortical atrophy to improve. We told them that this is not going to improve. Maybe we can halt further progression if that is the best scenario. Nothing else we could do. And patient was started on natalizumab for 6 months. 6 months later, cortical atrophy same, these white matter lesions same, but no enhancement now, no enhancement. So at least look at this. This is the brain scan. No enhancement is seen. So she took 27 months of natalizumab continuously, and nothing happened. But no further attacks occurred. There was no change for 6 to 7 months. And, I was wondering, 6 to 7 months have gone by, nothing's happening. She was unable to see patients. But the first thing they told me after 6 months is she had less depression and less fatigue. Now, how does one measure this? We couldn't, but, we just listened to the patient, and she said that she's less depressed and less fatigued. So this was the first real sign that something was happening. And it took 6 to 7 months. After about a year, her gait improved and she started walking independently. Lo and behold, it was amazing. She needed one person's support, and now she started walking independently. And the tremor affecting her right upper limb gradually decreased after 15 months. That tremor was something that unfortunately I don't have a video, but it was something to be seen, to be believed. So, you can't believe how severe it was. But that also went away after 15 months. And now she says that she is better by 70%. She helps her patients in the family-run rural hospital, but she is unable to see patients independently. So cognitively, she's a little down, but definitely better than what she was. And her verbal and writing skills have improved. And this is how her EDSS, her disability was. So 2008, it kept on increasing. 2009, it plateaued. We started Tysabri, and her EDSS improved. I couldn't believe it, that, she was not walking, and now she started walking independently. So her this thing improved. But now again, as usual, 27 months have gone by. Should we continue natalizumab? We are scared, we are scared of people. So antibodies to JC virus were positive. If we switch, to which therapy should we switch? Alentuzumab was available in the world market. It was costing 24 lakhs at that time. I had no real experience of it. I just heard about it from lectures, never used it. Nobody in India had used it at that time. Of course, now Netravati has used it and Dheeraj have used it, and things have changed. So, but at that time, it wasn't there. And there were good reports of BMT in the lay press, and a good center in Pune was doing it. And my friend, who's a hematologist, very good hematologist, he had done a few cases. So I said, okay, after much discussion, the family opted for bone marrow transplant. So bone marrow transplant was done in early 2016. She stood the procedure well. There were no adverse incidents. She was in the hospital for 6 weeks. She had to eat boiled food all the time, but she did it. Life settled down to a routine for 3 months after the procedure. During a holiday near the sea, tragedy struck once again. And she was totally paralyzed, totally unable to move, suddenly overnight. And, I got these frantic phone calls from the West Coast, Ratnagiri area. They had gone for a holiday, that, we are coming, and she's totally paralyzed and nothing. She was rushed to our hospital in an ambulance. She was conscious, alert, cranial nerves were normal. She was polyparetic, sensations were normal. Bladder bowel was spared, reflexes were brisk with extensor planters. And her MRI This is a plain MRI, shows the usual fixed deficit, but the contrast showed these large number of ring lesions all over the place, all over the place, extensive ring lesions. Maybe there were 20 or 25. Yeah, here you can see them in the coronal, in the sagittal view. So many of them here, all over the place, here. So maybe 25 ring lesions. So yeah. So again, we were, here they are, all these ring enhancing lesions. So still very active disease. So what happened? Was it another attack of MS? Was it an opportunistic infection? Because, she was, she had taken DMT and, or was it iris? So we didn't know at that time what it was, but we decided to give her methylprednisolone, and she improved very rapidly, amazingly rapidly. And she was, within 10 days, she was ready to take her family holiday overseas. And she went in a wheelchair and came back walking. They went to Southeast Asia, and they got me a whiskey bottle also, because they were so happy that she had improved. So question was, what do we do now? What is it? Wait, another DMT, alentuzumab, natalizumab, JC virus index is 3.5. So, it's really high. So, yeah. So now we have this JC virus index. And now if you see the index, if it is high, then the risk is much more than if the JC virus index is low. So, if it's less than 1.5, the risk is low, but if it is high, so what probably happened was, this is our conjecture, but I think we are right, that we stopped natalizumab, and the BMT really hadn't taken hold by that time, by 3 months. And when you stop natalizumab abruptly, you can get a severe relapse. So this is one very important lesson that we learned, that don't stop this DMT, natalizumab so quickly, and you can get a severe relapse. So it was an MS relapse, and she responded beautifully to methylprednisolone and started walking in 10 to 15 days again after that horrendous looking MRI. So we decided to restart natalizumab. Family totally aware of all the risks. 8 doses of natalizumab were given, but I started getting jumpy now, because the JC virus was positive 3.5. MRI, we said we'll do every 3 months, DWI and flare, patient doing well, EDSS 4 to 5, no tremor, spastic ataxic gait, helping parents in the clinic, savvy with computers. So then, to date, now we are giving her rituximab, and she takes it intermittently, every 6 to 12 months. She's doing reasonably well. Gait is independent. She's slow a little bit, slow in gait. She has mild ataxia spasticity, helps parents in the family-owned hospital, but not yet confident to see patients independently. But overall, I think she has done extremely well, and the parents are very, very happy and grateful. And this has been a great learning experience for me. And I'm sure people have questions and they can ask me. Thank you so much.
Thank you, Dr. Nashli. That was a really, really one case which what the trajectory took to the entire gamut of what the complexity of an individual case of MS.
Yeah.
Wonderful. So, Netra, if there are questions, then maybe now we have, I don't know how much time we've left with, but we can quickly take questions. And
Most of the questions have been answered in the chat box now.
yeah, some of them I did. I think some are still left.
Yeah.
I didn't go back to the chat box, but I think some have been.
So, Nasli, may I ask you, you think that bone marrow did not help in this patient? Was it a trigger for the iris?
We don't know, the Nirmal. I think it helped, but it takes a little time, for the immune system to get reset. And I mean, see, our experience is limited. There's not much data, so we I think it would take 6 months to a year for the immune system to get reset. And, we gave natalizumab again, she settled down. And now very rarely, I mean, I think once in a year, because they push me hard, that's why I give rituximab, but I'm not very much in favor. She's very stable now. She's settled down. So I think it did help, but she needed extra treatment off and on, to push it up a little bit. So that is what I think in her case.
If there are no questions on chat box, Netra, can I ask one question to the experts? So if, since we already have a whole lot of experience with rituximab, and probably the second largest rituximab experience from the world is from India. The first is in Europe, and I think the second is from India. If you collate all the cases that we have. So what has been your experience of developing PML with rituximab? The logic is the same, and you do have, so what has been, did any one of you see PML developing in MS patients? I'm not talking about other indications where rituximab is being used, with JC virus antibodies being, the index being high. Did you see any PML being developed in the Indian patients?
So we don't usually get a JCV for our patients who get started on rituximab, because theoretically that's
We
not
don't,
a risk.
Dheeraj. No, we don't. I know that. That's
And
why
we've
I
not
said
got a
that.
PML till date. We have not. I don't think so. There's any report of a PML with
Or
rituximab.
are we not looking for it?
Well, theoretically, even the screening protocols before most of these depleting drugs does not include JCV for rituximab, for a simple reason. You are depleting B cells alone, and you're not taking them out of the circulation. Whereas in natalizumab, you're almost removing all the T and B cells from the CNS. So there is zero TB cell in the CNS. That is a reason of a very high risk. Here, your T cells are absolutely fine with rituximab, and we are not totally just cutting down all the immune cells from the CNS or the across the blood-brain barrier. So there isn't theoretically a big risk in JCV, even in JCV positive patients.
Dr. Nashli, you wanted to say something?
Yeah. See, this JC virus index is only for natalizumab. It's not for other agents. But we do know that PML can occur with steroid therapy, with sarcoidosis, with lymphoreticular diseases, and with rituximab. So it is not a zero risk. It is a small risk, very, very small risk. I think 1 in 10,000 or 1 in 1 lakh patients. I've seen one patient of SLE on rituximab who got PML, and she's still with us, but not doing well at all. So it does occur. It's rare. It's rare. I don't think it comes into the equation of the treatment, but we must tell patients that it is a rare occurrence. It's nothing to be frightened about, but it's not zero.
So
From the MS, Dheeraj, one more from the MS registry so far, Dr. Rohit, did we have any PML cases for anything that you've given, fingolimod, natalizumab, rituximab, dimethyl fumarate? What has been? Maybe we don't have enough data to say that we can for sure say as such, but whatever we have right now, say, do we have anything to say from Indian patients that PML is big risk in this spectrum of DMTs that we have?
Not yet, ma'am. No reports.
Or maybe we're still not collating because we know that in our center we had a PML developing in a patient who took fingolimod. So, and who got well after plasmapheresis. So probably we need to just put in those cases as well and see if there is a difference ethnically, whether, we are more at risk, less at risk, or the same. Maybe there's a difference because we do use even combinations. There are a lot of questions in the chat box on combinations. So I assume in practice, people are using combinations of immunosuppressive therapy. We need to look for that. There's one moment. I'll hand over to Netra. I'm sorry. I'm keeping quiet now. You take over.
So there is a
Dheeraj,
one
yes.
question, Netra, since you all are using alectuzumab, Venkat Swami wants to know what is the risk of MI stroke or stroke if the people who have been used alectuzumab?
No, Nirmal, I'll actually, Netra can tell about her own experience as such. But
Yeah.
I think in the literature as such, alemtuzumab is certainly a drug which we need to be a little careful about. So I think besides MI and stroke and a whole lots of whole lot of issues which have been added on periodically into it. But I think in the last few maybe 6 months or so, we don't have further additions. But I think in the initial few years, every few weeks we had an addition of another sort of a red flag that this can occur. Netra, you can add on to that.
Yeah, actually, if you look into the spectrum of the side effects which we see with alemtuzumab, 30% of them usually have some thyroid dysfunction definitely coming up. It could be either spectrums of hypo to hyper, or even sometimes developing malignancy, but very less chance. But less than 1 to 3% themselves develop other complications ranging from MI, stroke, liver dysfunction, and dissection, carotid artery dissection, which has been there. But they're all single case reports. But if we actually take now, we have nearly more than 14 years of alemtuzumab throughout the world. Of course, in India, we have very less, maybe less than 20. But in outside the world, we have nearly 14 years of experience. And as ma'am mentioned, the last 2-3 years, we have not seen any new side effects coming up apart from what has been already reported previously. And definitely the larger, most severe and adverse side effects are less than 0.1%, 0.3%. I still
And
feel
mostly it's
uh,
infections, isn't
yes,
it? Netra, it's all
infections.
infections.
Yeah, I was about to tell that after the thyroid dysfunction, the next is the infection, especially if we have not streamlined the patients, asked them to have the proper therapy, which has to be done, the food restrictions, which has to be there in the initial months, and the COVID restrictions. Apart from that, the respiratory complications, UTI complications, especially the EDSS is high. These are the main things which we see. So thyroid infections are the most common with alemtuzumab, but that is also with any of the other monoclonals if we take. Not the thyroid, sorry, the infections with the rituximab also, which is there. I think that is the main thing. And the other
Just
thing,
to, yeah.
There's a last question. I think we should answer then. That's a very important question. And I think Rohit, Dheeraj, and Suresh, you give one thing. So this very good question is any good predictor which patient respond to which DMT? Because this is a question which many of these people who are still there and listening, they would like to know. So if Rohit one situation and Dheeraj one situation and Suresh one situation, which in that scenario, what DMT should be used?
I think as far as the beginning course is concerned, I think we should make a right choice right in the beginning when we have evaluated the patient. It's like saying someone who's come with a first episode of uh, event, and we have a reasonable idea from the imaging and the response to the treatment that this patient may do well on most of the DMTs that are available. Vis-a-vis a patient who comes to us who has already had more than 3 events in 1 year with a aggressive looking MRI, and we're going to make a choice of a very moderately effective DMT that's going to probably fail over the course of time. So I think one thing is the clinical course and the clinical impression that you get at the beginning when you are initially evaluating the patient. That's a key. And now I think we've learned that over the years. And as Dr. Nasli put it very clearly, way back, we had very limited options and we were very unclear about, and we were probably uncertain and scared to make those decisions. And as Dheeraj pointed out, the induction and the escalation route has to be clear from the beginning in a given set of patients. So I think that's my take on decision of a DMT for a specific patient.
Dheeraj?
So about predicting the response, as to be specific about the question, I think there is no answer to predict whether a DMT will work or not, because still we haven't reached that level of accuracy for personalized medicine. Biomarker studies, there were many studies which tried to look at predicting whether interferon would work in that patient or not, but nothing came out of those studies. So still what remains and what we know is predicting the disease course, just like Rohit said. So looking at the disease course prediction, we looked at MRIs, we've looked at relapses, characteristics of relapses, demographic characteristics. So that's best we can predict. This patient, for example, will have an aggressive course of the disease, and that too even right at the first attack. We don't even have to now wait for the second attack to happen. From day one course, from the first episode, if the criteria is fulfilled for RRMS, we are to a very high extent able to predict whether this is going to be aggressive. And then we can attempt to use high efficacy treatments. The rest is the same as Rohit said, induction preferably. And if there is a usual course of an MS or lower, not an aggressive MS, usual MS, a platform therapy should work. But there's no way to predict whether this TMT would work or not work. But we can at least try the best TMT as the specific nature of the MS.
Yeah, I would agree to that. What both of them have said, we have not reached the level of pharmacogenetics where we can tell that which drug would particularly help a person. But I would just keep my treatment into 3 first line, second line, and third line therapies, and there are a couple of drugs in each. So for the less aggressive MS, I would prefer first line therapies. And for the more aggressive MS, I would select from the second line therapy and later on the third line therapies if needed. I will also keep in mind if the patient is a male or a female, whether they are in the childbearing age or they are, going to become pregnant. And that will have a lot of, this thing in selecting the drug. Like I wouldn't give teriflunomide to women of childbearing age because that would not be the best choice. So probably, dimethyl fumarate or interferon or glaturoacetone would be better in that. So that will also, the age of the patient, what kind of work they are doing, their activity, all this actually helps. So there is a personalized treatment, but not at the genetic level. But keeping the patient as such, we would select.
Nirmal, can I add my 2 bits worth?
Yeah. There's
Okay,
one more
so
question. There's
but
one more
for
question,
the
Stop.
for
You add
this
that,
for
and then
for this part
Nasli
of
will
it,
answer that. No,
yeah.
Nasli,
No,
since
can
you have
I
put up
can
the,
I
Yeah,
Nirmal,
let Padma answer.
yeah,
no,
go ahead.
this part, I mean, the question that you asked about whether which drug to which patient, part
Correct.
of it, I think at this point of time, as I said, we don't have biomarker of personalized or, precise medicine. But yes, you do have markers of what are predictors of aggressive disease. There's a I mean, we have well laid out criteria for that. So when you
Okay.
have a non-aggressive, you have the first line DNTs, the choice in first line DNTs between injectables and oral, that is individualized. And also the being pocket friendly and also the gender based and whether they, they want to get pregnant, the marriage, everything. So that becomes individualized, but it is first line. And then the aggressive at that very point of time, then I go to level 2. Level 2, again, you have a choice. Again, this choice is economics, compliance, affordability, the choice of injectables versus oral. So, but for the choice of drugs, you have level 1 and then level 2. So between level 1, it is up to them. They can take as a free choice of whatever they need to do. So that way, I think we're pretty clear on what is to be offered to which patient as such. I think the last question, Nirmal, that you had for
Wonderful,
Dr. Nash.
Padma, wonderful. Nasli, since you have put up the point of rituximab and somebody has asked, and I felt that is important, you should answer to them. How do you monitor the effect of rituximab?
This is a little vexatious issue. We had a little problem with rituximab in the COVID period, and I was using it much less in these last 2 or 3 years, 2 years. Because this vaccination became a problem, how to give the vaccine, when to give the vaccine, how to give rituximab, because rituximab, if you give, the COVID was found to be a little more severe and few deaths occurred. So we were a little scared. But however, there is no foolproof way of monitoring. We do the CD19-20 count, and many of us believe without any proof, without any data, that if the count is less than 1%, then you can delay the rituximab. There is no proof and there is no study to show that. But we believe in our minds that, that means the treatment is adequate. And if the count is more than 1%, then we give the second or third dose of rituximab. But I would say you look at the patient, and every 6 months to a year, maybe you can repeat the rituximab. Now, we don't know the long-term effects of rituximab. I mean, it's an effective drug, no doubt about that. And in the Indian context, I think it is a very good drug because the yearly cost also is less. And, all these newfangled drugs, ocrelizumab and ofatumumab, they are also like rituximab. They have little less side effects and they are extremely expensive. So for the Indian setting, I think rituximab as a highly active therapy is a pretty good drug. And how to monitor this is a gray area. And as I said, CD4 count may help us as a pointer, but there is no evidence to show that that is the way to go. So we do it, but there is no hardcore evidence. Dr. Padma, I think, likes rituximab very much, and I think rightly so. Maybe she can add something, Padma.
Well, not personally, not that I love rituximab, but it's a practical choice. But again, as I said, that I think the registry is going to answer a lot of our questions. We just have to wait a little more. The MS registry, which is now built in, that definitely will answer a lot of questions about all the things that have been raised. And I don't think we have any more time, but we did not have any input on the new drugs which have come in, have been DCGI approved. And I do see that some of the neurologists are trying to push off the ofatumumab, which is apparently going to be launched. And as you rightly said, they're horrendously expensive. And I really do not know whether why do we have this monoclonal antibodies always tongue twisters? I don't understand this. But anyway, ofatumumab and
already available. It's already
yeah.
been launched in India, ofatumumab, and it's
Yes.
available.
So I think it's just the ease that it is subcutaneous and you just inject yourself once a month, and then maybe there's the ease. And of course, BTK, I think the tyrosine kinase ones will probably a game changer when they've actually come in because they're oral and they have different modes of action. Over to you, Nirmal. But Dr. Rashli, I think the answers are going to come from the registry.
Thank you, Padma, for your input. Netravati, you can comment and pass on to Dr. Bansal to summarize.
Yes. Thanks a lot. I think it was a wonderful session coming from the diagnosis from Dr. Rohit till the therapy from Dr. Dheeraj, and the importance of the non-visible symptoms. I think that is most important in multiple sclerosis, especially the cognition, behavior, which Dr. Suresh brought about very well. And Dr. Nasli's approach actually summarized, though it was just one case, it actually brought about different spectrums of different cases where we would also see such clinical scenarios. I think it was a very wonderful session. I hand over to Dr. Rajendra Bansal to close the session. So you're on mute, sir.
Unmute, Bansalji.
Thank you, sir. I think it has been an excellent session, excellent symposium on multiple sclerosis. Thank you, Dr. Nirmal Surya, for organizing 8 sessions in the first series, and Dr. Shyam Sundar, sir. Only thing which I would like to mention at the end of this series one is that probably we need to increase the participation of physicians, for which this IEN and API cooperation means with the vision of which you started this series. So that is one point. Thank you very much. Thank you all the speakers. It has been an excellent evening. Thank you very much.
Thank you, everybody. And I hope you will speak to the incoming president to take it forward regularly.
Okay, sir. Okay.
Nirmal, I want to say that congrats to you for getting the API involved and to being so active and keeping us on our toes throughout the week on every Saturday evening and even Sundays. So thanks again to Dr. Nirmal.
Thank you all for being there. That is what is most important.
Okay, thank you so much.
Okay, thank you, Dr.
Good night, everybody. Thank you.
Good
Thank
night.
you, everyone. Bye.
Thank you. Thank you.